My name is Shannon Sandford. I'm a registered nurse, and I have a doctorate in nursing education and a master's as an oncology clinical nurse specialist. First, I'd like to thank the committee for their efforts on Senate Bill 1075, an act to improve hospice and palliative care, a bill I also support because comprehensive quality palliative care is essential for our patients at the end of life. The establishment of a hospice hospital at home pilot program with a combination of in-person and telehealth visits will serve to increase patient access to services while allowing them to remain at home. And I don't believe this to be a redundancy to our current offerings, but rather an enhancement, and one that I wish was available to my family when my father was terminally ill. While I urge the committee to pass 1075, I also must implore you to support Senate Bill 1076. In my experience as a nurse, the best hospice and palliative care will not control all suffering. Suffering is unique to the individual. Florence Wald, who is largely considered the founder of the hospice movement in the United States and here in Connecticut, once stated, there are cases in which either pain or the debilitation that the patient is experiencing is more than can be borne. The American Nursing Association, the ANA, which represents the interest of the nation's 4 million registered nurses, guides nurses on the ethical decision-making since medical aid in dying is legal in 10 states and in Washington, D.C. The ANA encourages nurses to have respect for patient self-determination and a non-judgmental support for patients' end-of-life preferences and values. Self-determination and self-determination, prevention, and alleviation of suffering. They further clarify this by stating, in states where medical aid in dying is legal, patient self-determination extends to include terminally ill patients' autonomous and voluntary choice and informed request to self-administer medication to hasten their death. The nursing profession provides their ethics and guardrails that guide my practice. And as legislators, when you vote to pass Senate Bill 1076, which will be the strictest aid in dying legislation in the nation, it will guide the other part of my practice. I'd also like to mention that medical aid in dying is not synonymous with euthanasia. Euthanasia is inconsistent with the core commitments of the nursing profession and would profoundly violate the public trust. The key distinction is that medical aid in dying requires capacity for making a medical decision and self-administering the medication, all safeguards that SB 1076 requires. I've addressed these safeguards in detail in my written testimony, and I've come before the Public Health Committee numerous times testifying in support of medical aid in dying. SB 1076 is the most comprehensive and safest bill that has yet to been drafted, and I applaud the committee for their hard work on this bill, and I fully support its passage. I'd welcome any questions you might have. Thank you for your time.
Thank you, Ms. Sanford, for your testimony. My esteemed co-chair has a comment or a question.
Thank you, Mr. Chair, and thank you to Shannon. Thanks for your comments on 1075. And I have a question for you. You said that you think that it's not a redundancy, but will enhance the pilot program.
I do.
Enhance current offerings, and I'm wondering if you can just briefly say a little bit more about that, because what we heard earlier today in testimony was that this would be a redundancy and that the current law really covers this already. So just if you could just elaborate just a tiny bit, that would be great.
The current offerings for hospice home care, we do have an offering where during the last, the most aggressive forms of hospice care, they offer what they call 24/7 in-home hospice coverage for patients who are at the end of life. And while they do say, or they believe that this does cover the patient, this bill 1075 offers a much more comprehensive level of support with the telehealth visits and the in-house visits from the nurse. My own personal experience with my father when he was on hospice service was the 24/7 support was not comprehensive enough. I can recall a personal incidents where we had called hospice service for help, and the 24/7 support was, well, we don't have somebody that we can send out to your home. Perhaps you can call the fire department to come out and help move your loved one. It was constantly an issue where there wasn't someone available when we needed them. I think having the telehealth visits available on a daily basis would be much more comprehensive. I think having a registered nurse that actually is available to come out to the home provides much more comprehensive coverage. And I think that piloting such a program in Connecticut, where the hospice, where the hospice was founded, is a place where we can actually see real change start. Like I said, the 24/7 hospice support, yes, it's a telephone line that you can call, where they may or may not send somebody to your house, or they may just advise you over the telephone and expect you as the primary caregiver to be the person that provides the care. And I don't think it's comprehensive enough.
Thank you. Thank you for that answer. I appreciate it. And I also want to thank you for talking about the American Nursing Association and their guidance in the states that have already legalized medical aid in dying. That was also helpful. Thank you, Mr. Chair.